All right, let's get into it. We're going to build a consultant level guide to absolutely mastering the supracondylar humerus fracture. Think of this as your framework, the key knowledge you need to walk into any orthopedic viva and just nail this core topic with complete confidence.
So here's our plan. We're going to follow a really logical path, okay? We'll start with assessment and fracture types, move into radiographs and how to classify them, then cover the principles of treatment, get into the nitty-gritty of managing each type, talk about the actual reduction technique, and finish up by tackling that classic pinning debate.
First things first, any viva, any real-life scenario starts with a safe and systematic approach. So we're starting right where you would be in the ED, assessing the patient who's just come in. So picture this. Your patient is almost always a child, usually somewhere between 5 and 7 years old. And the story? It's the classic fall on an outstretched hand, a foosh, with their elbow hyperextended. You need to be able to state that mechanism clearly and confidently right from the get-go. Now, that mechanism leads to two main fracture patterns. The vast majority, we're talking up to 98% of them, are these extension-type injuries. That's where the distal piece gets shoved backwards. The other kind, the flexion type, is much more rare. It's usually from a direct hit to a bent elbow. It's important to know about, though, because how you reduce it is completely different. Okay, this next part is absolutely non-negotiable. Your neurovascular exam. It has to be meticulous, and you have to document everything before you even think about reducing this fracture. You're looking for that telltale swelling and bruising in the front of the elbow. Then check the vascular status. Is the hand warm and pink? You're not just feeling for a pulse, you're getting the Doppler out. Capillary refill needs to be under 2 seconds, then you methodically march through the nerves. The AIN is the one that gets hit most often in extension types, so you have to check that A-OK sign. Then you test your radial and median nerves, and please don't forget the ulnar nerve. It's the one at risk with those flexion-type injuries.
Okay, initial assessment is done. Now it's time to look at the pictures. How do you systematically break down these x-rays and communicate what you're seeing?
On your lateral view, there are two huge signs you have to look for, even if the fracture is barely displaced. First, if you can see a posterior fat pad, that's always a red flag. It means there's fluid in the joint, probably blood from the fracture. Second, and this is key, you've got to check the anterior humeral line. And this is just such a beautifully simple tool. All you do is draw a line straight down the front of the humerus. On a normal elbow x-ray, that line should slice right through the middle third of the capitellum. If the capitellum is sitting behind that line, you've just confirmed an extension-type fracture. It's elegant, simple, and incredibly reliable. So now that you've identified the fracture, you classify it. And the language we all speak here is the Gartland classification. Type 1, non-displaced. Easy enough. Type 2, it's displaced, but that posterior cortex is still intact, acting like a hinge. Type 3, it's completely off, no bone touching at all. And then there's type 4, which is a bit of a special case. It's completely unstable in both flexion and extension, something you usually diagnose in the operating room. Okay, so you've classified it. How does that translate into a management plan? You know, a really great Viva answer always brings in the national and international guidelines, like the ones from BOST or the AOS. It shows you're practicing evidence-based medicine. And the guidelines from the American Academy of Orthopedic Surgeons really spell it out perfectly. For a Gartland type 1, you're looking at non-surgical immobilization. Simple. But for the displaced ones, the types 2s and 3s, the recommendation is clear: closed reduction and pin fixation. It gives you a really clean, evidence-based path to follow. But how fast do you need to get to the operating room? This is a really critical point, and it all comes down to the vascular status of the hand. If the hand is well perfused, you can safely wait and put the patient on the list for the next day. If the hand is pulseless but pink, meaning it's still warm and well perfused, that's urgent. You're going to the OR that day. But a pulseless, pale, cold hand, that's a true surgical emergency. You have a matter of hours to restore blood flow and save that limb. All right, time to execute that plan. In a Viva, you need to be able to say with no hesitation exactly how you would manage each Gartland type. So for a nice, stable, undisplaced Gartland type 1, management couldn't be more straightforward. It's a long arm cast, usually for about 3 to 4 weeks. But the key thing to mention is your safety net. You're bringing them back for repeat x-rays in a week, just to make absolutely sure it hasn't slipped in the cast. Now, the second that fracture is displaced, so a Gartland 2 or 3, your management shifts gears completely. Now we're talking about surgery. The gold standard here is a closed reduction and percutaneous pinning, or CRPP, and that's done under general anesthesia in the operating theater. Describing the actual surgical steps shows a much deeper understanding of the problem. So, let's walk through it. What are the key moves to get this fracture reduced? The reduction itself is basically a 3-step dance. First, you apply good, steady, longitudinal traction. You're trying to pull the bone ends apart to disengage them. Step 2, you correct any sideways tilt, that varus or valgus deformity. You just manipulate the form to line it up. Finally, while you're still pulling traction, you fully flex the elbow. This tightens up that posterior periosteal hinge and just locks the reduction in place, all ready for you to put the pins in. Now, if you really want to show the examiner you're operating at a higher level, you have to talk about the areas of debate and controversy. And for supracondylar fractures, the big one is all about pin configuration. And here's the central question you need to be able to discuss. Should you use a crossed pin construct, one from the medial side, one from the lateral side? Or should you just stick to the lateral side and put all your pins in from there? So let's break down the arguments. Crossed pins are biomechanically rock solid. They create a really strong, stable fixation. The big downside, though, is that when you place that medial pin, you are putting the ulnar nerve directly at risk of injury. On the flip side, if you use only lateral pins, you completely avoid the ulnar nerve. It's just inherently safer. The whole debate really centers on whether that lateral-only construct gives you enough stability, especially for the more unstable fractures. It's the classic surgical trade-off, stability versus safety. And it's really important to frame this as an evidence-based discussion, not just your personal opinion. There are countless studies and meta-analyses out there, just like this one, that are constantly comparing the outcomes of these two techniques. Mentioning that you're aware of the literature shows you're engaged and up to date. So we'll finish with this, a provocative, real-world challenge. You've just done a beautiful reduction and pinning. The hand is well perfused, it's warm, it's pink, good cap refill, but you can't feel a radial pulse. What is your next move? Do you rush to explore the artery, or do you sit tight and observe? This is the kind of scenario that really tests your clinical judgment under pressure, and it's exactly the kind of tough question you need to be ready for.